specialist, and they said, we just need you to write a bio. And I was like, that's all the instruction you're going to give me? All right. So I wrote a bio, but it was just a joke. And it kept going. I didn't mean for it to be 2 pages, but it did end up being that way. It was kind of fun. Anyway, so what we're going to talk about today, and let me first thank y'all for inviting me to talk. I'm kind of, this is kind of a topic that's important to me, for which reasons I volunteered to be on the County Committee and the Foley Catheter Policy Committee and all sorts of other things. And we're trying to basically educate everybody on how to put these things in, because what I think has happened in the past, or what I'm pretty sure it's happened in the past, I started working in the hospital, I was in the ER when I was like 17 as a candy striper, at least that's what they call us. We had to wear the red and white striped shirt, we were volunteers. And from what I could tell, it was like, hey, the guy in whatever room needs a Foley, and it was like, you're too slow, you gotta go do it. So, and my approach to Foley catheters is that's not how it ought to be. Really, you need somebody who knows what they're doing to put a catheter in. And I think if you've ever had one, you definitely agree. I haven't, but I've seen what happens when people who are uncomfortable and whatnot put them in. The other reason to do it is, I think one of the reasons that, catheter-associated urinary tract infections, if that gets documented on a patient's chart, then that hospital visit from there on is on us, on the med center, and they get no more money from Medicare or insurance companies for the result of that. And so I think one of the things that's important is to recognize that. And we won't introduce what we're talking about yet because we're not quite done with policy and everything, but putting a catheter in is one of those key elements in that discussion. So I was on a committee in St. Louis as a resident because we got calls for difficult Foley catheters all the time, and so I kind of have been doing this for a while. So let's see, forward. Which button is it? If it works. All right, well, not a problem. Let's do this. Okay, so this is my warning. If you've ever watched South Park, this is for you. I did put this in for Tracy. All right, so you can't really talk about urology and Foley catheter placement without trying to make this not boring talk, because otherwise it would be incredibly dry and mundane. And I myself fell asleep through many lectures in medical school, so I figured my goal would be not to do that to y'all. So what we're going to talk about a little bit is the anatomy, male, female, and then actually of the Foley catheter, because that makes a big difference as well. Placements, some common errors, and some other thoughts that will kind of help you out. Indications for catheters, they're really, the biggest one we're trying to address in the policy is that an indication for the catheter is not because the patient's incontinent, or the family wants it, or not very many patients want it. But really, accurate ins and outs and urinary retention or inability to void, those are the two big ones. And then the last one I throw in there is because we said so as urologists, because that's kind of our thing. And sometimes we leave them in for various reasons and don't want to take them out. So it's in the newspaper, Tracy.
I know.
I'll read it to you. All right, so male anatomy, there's a natural S curve in the male urethra, in a sense that in the flaccid position, using medical terms, you have urethra comes up here, and then it actually enters into the body here, drops down, and then comes back up into the bladder. And that double S shape kind of presents a problem if you're not doing things correctly. So one of the first things to recognize is how the urethra runs, and then some trouble spots that you're going to find. So the most common reasons that I've put together that I get called for difficult Foley catheter: phimosis, meatal stenosis or hyperspadias, penile edema, concealed penis, also known as Dunlap's disease, because your belly Dunlapped over your belly. I had one patient who told me, he said, my dad told me if I had something I cared about, I built a shed over it. Like, all right. That means you can't see it anymore. So BPH and urethral strictures. So the first thing I'll see is somebody who's inexperienced placing a catheter is how you're holding things, because you've got to understand the anatomy just like in anything else, and that's one thing we're trying to stress in the policy committee. This shouldn't be just a catheter. It'll be kind of treated like a central line because it isn't a somewhat invasive procedure. But the urethra, if you were to Lorena Bobbitt the penis, what you see is the corporal bodies which generate the erection, and then the sponge and the urethra are down here at 6 o'clock. So the urethra runs at 6 o'clock all the way down the urethra and up, like in the picture here. And if you grab the penis and hold it with your thumb at 6 o'clock, you've already set your first obstacle, and the catheter's not going to go beyond your thumb. It's your thumb. You're doing it. And I've seen that all the time, and the first thing I'll do is I get called and they'll say, show me how you were doing it. And this is the most common error I see. So then you hold the penis out on gentle traction, and that straightens the first curve out of the urethra. So up to the ceiling, you never do this. Okay. And that'll eliminate the first S curve. The second is the lidocaine urojet. This is really something that I think everyone ought to have. I mean, we're going to roll it. I don't know if it's already been rolled out, but it's supposed to. We'll talk about that later. But the reason you use the lidocaine urojet is twofold. The first is you can tell the patient, particularly the guys, and give you some numbing medicine. Now, half of the numbing medicine is placebo effect, but who cares? They still think, and it's going to make them more comfortable and more relaxed, and it's going to make them feel like you care about what you're about to do to them and recognize that it's not something that's comfortable. The real reason to give it is that the gel itself goes in and opens the urethra, because by definition, much like the bladder when it's decompressed, the urethra coapts, and so it's not a solid tube, it's a coaptable tube, so the penis can, come down so guys can run around and do things. Otherwise, it would be this solid tube running through there and it wouldn't be uncomfortable. So, if you don't have lidocaine urojet on your floor, if it's not accessible, if it hasn't been rolled out yet, there is a really specific reason why, in case you've ever wondered this, like why does the syringe, the lubrication comes in look like that? It comes because you can use it for the same principle. It is designed specifically to be injected down the urethra. So you put just enough. You're not supposed to squirt the entire thing out on your drape for your prep. You're supposed to squirt it down in the urethra. It lubes up everything and lets it all, it helps the catheter slide in, opens the urethra, and will make the entire Foley catheter placement much more comfortable. And I have no problem with the little white lie that if you don't have the lidocaine, you just tell the patient that this is numbing medicine, because they're not going to know. And honestly, the lidocaine, we don't, only in the office when we're doing cystos do we let it sit for 10 minutes before we do anything. So, I mean, come on. It's like the stuff you put on for IVs. I don't remember the name of it, but you got to give it some time to work. We don't really do that here in Foley catheters. We don't make them hold it for, you just have the patient squeeze their own, keep it in. I mean, we have little clamps. But you don't have to really do that. It's really more of the placebo, and what you're really doing it for is to open the urethra. Hub and the Foley. This is huge. My wife's a nurse. She told me in nursing school when they were taught to put the catheter in, when you got urine back, it was safe to blow up the balloon. And that's false. Hugely false. Look at this picture. The tip of the catheter and the balloon are separated by about 1.5 centimeters. And so, when you're in the bladder, this is assuming you're inside the bladder. I actually stole this picture off the New England Journal Foley catheter presentation that's available on the website. But you can see that the tip of the catheter can be in the bladder. You will get urine back. The balloon is not. And if you blow up the balloon right after you get urine back, it may very well be in the prostate. Or not even all the way in the bladder. This is a real case here from the Med Center that I'll touch on briefly throughout as my example of the worst Foley catheter trauma I've seen. There's actually litigation ongoing, but can't talk about it, I guess. I don't know. Does that look right to anybody? I I mean, you could walk up to the bedside and say, that's not in. Who blew up this balloon? Yeah, it did. Who blew up this balloon? And this was in one of our ICUs. Or the ER, I can't remember which. It's been kind of a while since I was deposed. All right. Don't inflate till you get urine back. So you want to make sure you hub the catheter and you get urine back. One of the biggest things that will happen if you use the lidocaine urine bed is you want to immediately get urine back, which makes me more comfortable with everybody placing the catheter because they won't blow it up in the prostate. Downside is you may have to kind of manipulate things a little bit before you get some urine back because that catheter will pick up gel as it goes through, and it's just included by, lube, really. And usually just a simple push on their belly, suprapubic region, will force the urine through, and then you'll see urine come through. If that doesn't work, you can flush the catheter, get it out. That's, here's a tip my chairman told me when I was a little resident way back when. Stare the guy in the eye while you're blowing up the balloon. I mean, if he's not worked out, he'll tell you if it hurts. It shouldn't hurt at all. It's in a big bladder. I mean, it should cause absolutely no pain whatsoever. If they start screaming, it's not in the right spot. Don't fill it. Stop where you are. Get help, readjust, whatever. And then kind of try to feel for resistance as you're placing the catheter because the person you're going to call next is going to want to know, hey, where'd you meet resistance? Where was the trouble? Was it right when you started? Was it midway through? Strictures in the male urethra come from different causes in different places. So in the bulbar urethra, that's the most common cause, or that's where you find STD-related strictures. Membranous stuff is from trauma and sometimes getting kicked as a child when you were annoying people, I hope. And then at the bladder neck is usually something that we did to them, or the prostate. Again, this is kind of a work in progress, who we call, but this should be, not here to see this either. Unfortunately, this is her internet picture. You can't get that. But we're working on something, house coordinator versus the C3s or somebody. But right now, 9 Main is our main go-to resource for catheter placements because that's our home base, and most of them are exceptionally good at placing catheters. All right, so going back to that first picture where the catheter was clearly not in. This is an aortic runoff. This is an aortogram. All right, this is that patient. He went to the OR 3 times with me, trying to get his bleeding to stop, and I couldn't. And what you see right here is, so what they did is interventional radiology puts the catheter up, squares contrast in the aorta, and takes pictures of where it's running off. And right here is a blush. It's what they call a blush of contrast. That's a active bleeding site. That's the urethral artery. This guy's trauma was so bad that he had a bleeding artery in his urethra as a result of what should be just a fold. This guy he's got real long-term problems. So anyways, BPH. So what is it? You hear about it, but what is it really? Well, if you cut, this is what I tell my patients, this is the exact spiel I use for my patients. BPH, if you cut to the prostate like a loaf of bread, you see a donut. And as guys get older, that donut hole shrinks. And after age 50 is usually when it starts. So if 50 is the average, that means there's some people in their 40s that have trouble, some people who don't have trouble in their 60s. So you got to remember that as you get older. I mean, if you're in the ped section, you'll never have this trouble. Children's Hospital, there should never be a prostate issue because kids almost don't have it. Pediatric urologists don't know what to do with prostates. Seriously. One of my best friends is a urologist. We were studying for our boards. He was like, dude, what is all this prostate stuff? This is what it looks like on the inside. This is a cystoscope in the urethra looking in through the prostatic fossa, and you can't see the bladder. You ought to see a big black opening, which would be the bladder full of fluid. You can't see anything except prostate tissue. That's what you're up against when you're trying to place a catheter in a guy with prostate, big prostate gland. And tips on their med list, these are the meds that we use for
radiation. The guy may say, oh no, I don't have it, because I've seen plenty of patients say, I don't have high blood pressure anymore, because you're on 6 medicines. But you still have it. Pressures are controlled, but you still have hypertension. These are our medicines: Flomax, Rapaflo, Uroxetrol, Avodart, and Proscar, and then their generic names. I can't tell you all of them. The Tamulosin is Flomax. I never learned Rapaflo or Uroxetrol because I hated it. And then finasteride and dutasteride. All right, the Coude tips. These have already been rolled out. These should be available on every floor. Any guy that's over the age of 50 or tells you he's on one of those medicines, you probably ought to use a Coude tipped catheter versus a regular Foley. Here's the difference. There's a tip. Coude actually means elbow in French, I think. Perkel told me. I don't know if that's true. So if that's not true, it's Perkel, not me. But there's an actual bend in the tip of the catheter. And what that does, back up. You know the bend is at the top. You want it pointing at 6 o'clock. And you know it's there because it's always with the balloon port. So the people that made this catheter made it standardized so that you'll always know. Because once you put the tip in, you don't know which way it's pointing. And if it's going down or sideways, it's not helping you. You want the tip pointing towards the ceiling. So there's a little notch here. There's also the balloon port is always, if that's up, so is the tip. So you can see here it tips up, balloon port's up. Sometimes you can see a little black line running down the top of it, but I don't think that's the one we got. You want it in at 12 o'clock on the face of the clock, so your balloon port faces at 12. I'll tell you this, so here's the tip. I mean, here's what it does. It hits this at a much different angle than straight on, like this one would. It kind of slides on in through a big prostate. Does that kind of make sense? Mm-hmm. Now, tip, if it comes in the kit, which is what we've ordered, last I was told, that means the bag's already going to be attached, right? You may have trouble with orientation because the bag may be pulling on the catheter. So one thing to do is to get your bag out of the box that it comes in and let it hang kind of straight and uncoil it so that you have a little more control over the distal end of things and make sure that your balloon port stays at 12 o'clock so your tip stays at 12 o'clock. All right, female anatomy. You'd be surprised how many of my patients don't know what their actual anatomy looks like, which is interesting. We do actually, as urologists, see about 25 to 30% female, and it's gotten higher. It's probably almost 50-50 now with incontinence because a lot of the OBs don't want to deal with it, which is fine. So, figure of 8, vaginal opening, the introitus, and then the urethral meatus. So I have seen in 10 years of being a urologist, I've seen 2 actual females that really warranted a urology consult for a Foley catheter replacement. And both of them, one of them had radiation to her for uterine and cervical cancer. And the other was an older lady, like in her 90s, and her urethra had retracted backzone, was actually up behind the pelvis. This is what we do. I mean, there's no special tricks to it. It's not like the male where you get a lot of stenosis. Some women do require dilation, but you have to do to get a 16 catheter in. Bedpan, tilt up the pelvis. You can put the bed in Trendelenburg. I think I spelled that right. If there's any spelling errors, I forgot to give you a disclaimer up front. I never made it past the first round of the spelling bee, ever. You put the bed in Trendelenburg, that just makes it easier for you to get the pelvis up, and so that you're looking more bed in. Completely prep out the vagina. The little Q-tips aren't going to cut it, so get a box of 4x4s and some betadine and just do a good prep so that it's as clean as you can get it. Because what you're going to do is you take your non-dominant hand, so if you're right-handed, stand on the patient's right side, put your left hand in, your finger in the vagina, come up to the anterior vaginal wall, and then slide the catheter along your finger. The next hole up is the urethra. So you kind of set yourself up for success by occluding the other hole that people put the catheter in and then don't get any urine back, right? So it's really, and if it's back up behind, if it's an older lady and you think she's going to have a retracted meatus, what have you, from the absence of estrogen, use a coude tip. It's not gonna, it's not just for men. Like, yourself, all right. You can use the same thing. It'll help you slide up and then kind of make that little curve and get into the reefer, but it's still not impossible. It's very easy, really. All right, this was an actual birthday card I got. And it's funny that what happened was when I got down here, I caught myself. I was doing a rectal exam on a guy and checking for prostate cancer, and I was like, that feels good. And then I was like, wait a minute. So you have to be really careful when you say it. It's like, not so much good. Your prostate feels fine. That's what I'm going to say. All right, so the three-way catheter. This is something that I've found just in being here for a couple of years that a lot of the floors besides 9 Main have a lot of trouble with. The concept of the three-way catheter and what it's for. Three-way catheter is in place really for blood. The only other time I've ever seen it used besides the is every now and then infectious disease will want to run intravesical antho B or something terrible into the bladder, and that's the only other time I've ever seen a three-way catheter used for anything. So three-way is always going to have a bigger hole on the tip of it than a regular catheter. So try and imagine getting a blood clot out through this. It's much easier through this. The other reason that there's usually a hole at the tip on a three-way catheter is because bladders are distended back, right? So it's like a water balloon. And if you've got a catheter and somebody says, irrigate the Foley, and you put in 60 cc's and you pull back and you get nothing, doesn't mean that your catheter's not working right. It means that as you pull back, you're sucking the bladder wall right up against this hole. So you're not going to get anything back. So put in some more until you've got a distended bag of fluid that you're working in, because that's what you really want the bladder to be. Normal bladder capacity should be around 400 to 500 cc's. So if you're putting in 60, 120, around 120, 200, you ought to be able to irrigate pretty good. And chances are, if you're doing it gently, you're not going to rupture anybody's bladder. It's very rare. And if you do it by gravity, you'll never rupture a bladder, unless there's already a hole there, in which case I would blame one of the urologists across the river. So, all right, so it's CBI is how we'll write it. It stands for continuous bladder irrigation. One of those few terms in medicine actually makes sense, I think. So you've got your inflow. So this is a 3-lumen catheter. So by definition, a regular Foley catheter is a 2-lumen catheter. The only single-lumen catheters are the Robinells or the Red Robins, it's a straight catheter. So you've got your inflow, outflow, and then your balloon port. The whole point of CBI is to prevent clots from occurring so that the patient's urine can get out. I would tell you, forget about trying to keep up with ins and outs. It is a nightmare because you've got bags of fluid going in, and then you're going to get more. As long as you're getting out more than you're putting in, you're okay. If you're getting out less than you're putting, there's a hole in the bladder, and that's a problem. And never, ever hook it up to pressure. That's happened once. Don't do it. You'll perf a bladder under pressure. It's happened. Don't put it on an IV pump either. Just don't put it on any pressure whatsoever. All right. All right. Some final thoughts. Irrigating a catheter. This is my pet peeve. This is not an irrigation port. This is for aspirating a urine specimen for culture, and that is it. If you try to irrigate this, don't tell me you're doing it, because you're not irrigating. You've got to break the catheter apart. By that I mean break the Foley catheter from the drainage system, and then put the 2 meter slip tip, same thing you use for an NG tube, and irrigate the catheter. When you do this, everyone always says, well, we can't do that because we're breaking the sterile fill on the catheter, and you're going to get an infection. That may be true, but if they don't pee, that's worse, number one. Number two, if you're doing this, probably they have blood in their urine. So they're going to have the diagnosis code, or they should have the diagnosis code of hematuria. If you've got the diagnosis code of hematuria, you can't have a CAUTI. You can't have a catheter-associated UTI. So break it apart. It's more important to get the clots out and keep their urine flowing, keep the patient comfortable, than it is to worry about the risk of infection. Once you get the bleeding under control, I'm sure we'll be called, so you won't even have to worry about it because they call us for all hematuria consults anyway. So just don't, when we get up there, don't tell us you irrigated and show us and it's to this port. I'm gonna be upset because that's not irrigated. Stat blocks. There's a lot of discussion about where to put these things and all that. As long as you're not putting the catheter on a bowstring, it almost doesn't matter where you put it. Give it some play. If you tape that thing down, put the stat block down by the guy's knee, well, guess what's going to happen when he gets to walk? It's going to hurt like a son of a. Or he's going to pull his catheter out. So give it some slack in the catheter when you put it up on the thigh. And if it's going to be in for a longer time, and this is something that'll roll out in the policy, and I've already talked to Dr. Cunningham, and we've already started teaching them to put in super. But if you're going to have a catheter that's going to be in place for greater than 2 weeks, you really ought to put it up on their belly. And the reason is because the urethra is the weakest point of there's no support behind the urethra, whereas you got the corporal body supporting you at 12 o'clock. And this is what happens. Urethral corrosion. Sorry, I'm glad you already ate. But that does happen, and it is preventable. Easily preventable. Leaking urine around the catheter, that's another thing that always throws people off. That's a bladder spasm. Just because that balloon is there doesn't mean that no urine can get out. So what will happen is the balloon, and I put finger quotes around tickles, the bladder contracts. And it generates enough pressure that you'll fire urine out around the catheter. That's not a problem. It's pretty much being expected, especially in the younger patients that have catheters in, because their bladder's a little more not used to it. Some of the older guys have on catheters forever, bladder's used to it. But ditropan and B&O suppositories, if the medicine resident that you've got doesn't have a clue why they're leaking around the catheter, you can suggest this to them. Well, the urologists usually say that try one of these medicines. That's like when I was an intern, I called nurses, they called me with something, and they said, oh, so-and-so's potassium is low or whatever, and I'd be like, well, what would Dr. So, and if they're rude to you, well, that's their loss. Bladder scanners, all right? So we've gotten 4 more of them because there's not a lot in the hospital. We've ordered 4 more. These things are great, but there's one time where they are worthless, and that is ascites. If you've got a patient that's got ascites, if their belly looks like this and they're not pregnant, chances are this thing's not going to be accurate. And the reason is this is not a smart ultrasound. This is not the same kind of ultrasound machine that you get with when radiology comes up to do an ultrasound. It's just looking for fluid. That's all it's doing. So that's ascites. You put this little thing on their belly and it's going to read 999, greater than 999 every time. It'll give you a huge amount of volume. And you'll be like, but your urine output, the catheter's not working. Oh gosh, what's going on? It's ascites. You can't, bladder scanners are inaccurate. So, I'll leave you with this riddle. Tell me when to click it. Everybody ready? That was a 3-letter word that rhymed with grass. But I didn't think Tracy would want that, so I had to make the request. Any questions? Thoughts? Comments?
At the first lecture you did for the GDs, you made some comments and gave some instruction on patients with female prostheses.
Right, good point, thanks. If they've got a prosthesis or a sphincter, an artificial urinary sphincter, they ought to tell you, and I tell my patients, look, it's your responsibility to let people know you've got this. Like, I put this in so you can still have fun. You need to make sure you tell anyone who goes to put a catheter in that you've got it. If they don't tell you or they can't tell you, the easiest way to tell is a third testicle. That's the pump. A hard structure in their scrotum. There'll be a pump. I got no problem with you calling urology and say, hey, I got a patient here with some sort of artificial something. He's got a third testicle, an EP, extra testicle. All right. And what do we do? And, you know, if it's a sphincter, really, they ought to call us. I would much prefer we come put that catheter in, because if you jam a catheter up against the sphincter and you erode the mucosa so that it's exposed, that's a trip to the OR for that patient. So if it's a sphincter, really, and you're not comfortable with it, I'll never fault you, and I don't think any of my partners would either, for calling us and saying, I think he's got an artificial urinary sphincter, could you put this in? Because you got to deactivate it and then put the catheter in. In a prosthesis, a penile prosthesis, it's just going to make things a little bit difficult, and you want to, if you can, you want to go down in size a little bit. You don't want to ever go over an 18, which we wouldn't want you to try anyway. That would be the Foley team. But if they've got a penile prosthesis, it's just the amount of pressure that's going to be put on the urethra. Same thing. It can erode, and then that's a trip to the OR, an excision of the device. So if somebody's got an artificial urinary sphincter, and you have to take that out, that means they're going to be totally incontinent of urine. And that's a pretty rough thing to do just because you couldn't get a catheter in. So I would say if they've got a sphincter, call urology. You'll never get mad. Just say, hey, I got a guy with needs a catheter, he's got a sphincter. That's anything else that I forgot on this one?
No. I filled in my notes from there.
We did address how the nurses can perhaps recognize that if there's a way to do so with managing the scrotal edema and the penile edema.
Right, that's a good point. We did talk about that last time. Penile edema is one, so a lot of these things that we're getting consulted for aren't legitimate urology consults, meaning they're things that can be troubleshooted without pulling us out of the office or the OR to come and do. Penile edema is the easiest, followed by penile concealment, the Dunlap's disease. Penile edema is penile and scrotal edema when you're supine in bed for an extended period of time. The most dependent portion of your body, instead of being your legs when you're standing, becomes your sacrum and your scrotum. Penis didn't seem like it would be supine, but the pressure built up. You can get edema to the penis as well. It's always in uncircumcised guys. There's never going to be a guy who's circumcised should never have significant penile edema to throw you off. And it'll look like, you remember those little squeezy things that you play with as a kid, that you could squeeze the fluid from one to the other? That's all it is. It's just fluid. So you can give the guy some pain medicine if he's got any written for it. Or if he doesn't, you can do it with really gentle pressure. I would say ask the admitting physician for a little something for, a little IV something. But all you do is squeeze. And it sounds terrible, but I've done it without any narcotics, and it's not that bad. It's steady, gentle pressure. So you don't just go up there and put a vice grip on it and squeeze the crap. You just kind of start slow and squeeze your hand until you close your fist and hold it there for, 5 minutes or so. It doesn't hurt, believe it or not, if you do it gently and everything. When you take your hand off, you'll be amazed. All that fluid has gone out of the foreskin and is back into the space, in the interstitial space in the pelvis, and you can retract the foreskin enough to see the meatus and put your catheter in. Penile concealment, the Dunlap's disease, you're not taping anymore, right? Good, she stepped out. We call it the mangina because you can't see anything. It can be that bad where you really can't see a penis in your lifetime. I mean, it's a guy, but what you do is it's a two-man job to place a catheter, sometimes a three-man job, person job. Pressure down in the direction of where the penis ought to be will reveal the penis. And then you just prep it out while that person is holding, or those two people are holding, each pressing on one side. Depending on people are getting bigger, it's much more difficult. And then the penis will show up. And if they have a phimosis, different story, but usually it's just a concealment, and it's relatively easy to see if you push in the right direction. For females who are very large, even with them in the frog leg position, you still may not actually ever be able to really see. Just prep everything out and document that it was very difficult Foley catheter replacement, so that that'll help with county rules. We can go back and say, well, yeah, yes, you got infection, but come on, look at her body average is 800 pounds. You laugh, put a super pubic tube in a guy that was, I don't remember how much he was doing before ICU. Something like 600, 700 pounds. Yeah, I mean, that's just, we had to put 2 OR tables together because they don't hold that much. It's really, really sad. What else?
I wanted to talk about scrotal edema and managing that, because I know we've had
Right.
some injuries that were associated.
Right, and we're addressing that in the ICU. Right now, what Dr. Cunningham and I have talked about doing is if somebody's going to get a trach and a peg, we called it, at SLU, we called it the ICU hat trick. You got a trach, peg, and a suprapubic tube. It's just easier to manage. And that actually brings up a good point. But let me just say this, suprapubic tubes, a lot of nurses will call us and, oh, we can't change a suprapubic tube. It is the easiest daggone thing to change in the world. It's a straight shot. The bladder is right there under the skin. And if the tube's been in there for a long time, it's an established track. It could be out for a day, and you still be able to get this tube back in it. That is the most, like, irrational fear of all holes in bodies. I mean, it's a straight shot in. It's the easiest I put it in for a lot of my I use them a lot. And I'll have the families. If the patient can't do it, I'll tell the families to do it. I mean, you don't have to drive up here every 4 weeks. You can do this yourself. It's so easy. All right, so that being said, scrotal edema, the best thing to do is to manage it by elevating the scrotum. A rolled towel is the easiest and the best thing. There's something called, what's the name of the bridge? It's a city in Illinois, whatever. You can take a piece of tape, silk tape, and run it, a green towel over it. So the tape is taped to both sides, and then on the sticky side you got this towel and support the scrotum. But the scrotal edema there's really nothing you can do about it. The guy can't get out of bed and walk around, it's not going anywhere, he can't drain it. And if the skin starts to break down or it starts to blister, there's, outside of routine wound care, there's really nothing you can do about it. It's just one of those things. They'll call us all the time for scrotal edema. What do you do? I can't cure his liver failure, and therefore he's in ICU. Other than putting the towel under the scrotum, there's really not much you can do for it, other than try and protect the urethra. So what was happening a lot of it was in the ICUs. I don't mean to single out the ICUs, but I mean that's where people are going to be unable to get out of bed. And they would have the catheters in. These guys would have massive scrotal and penile edema. You got this rigid tube running through this urethra, and it would hang on the side of the bed with plus or minus a stat lock. I mean, some of these guys would sweat and stat locks wouldn't stick, and I mean, I know that. It's not like they weren't putting them on. And then that catheter is under traction, and it would erode through the skin because it wouldn't get, I mean, this is a perfect example. Put it on the belly and secure it up there, and you won't have that problem. We're going to supersede it by pretty much, I would say by this time next year, Cunningham probably won't be calling me to put suprapubic tube in. They'll do them themselves at the bedside at the same time they trach and peg. So that ought to kind of not be as big of a problem. We know it's a real problem. We're trying to address it. Anything else? Yeah.
The Coude isn't available in the urine metering kit. Ours doesn't offer it that way. So if you want to have the Coude catheter, you have to take the regular catheter, break the sterile field, and then add the Coude.
And if you do that all, just for the record, I do that all the time. In fact, I rarely ever put a catheter in that's attached to the drainage system, just because. And if you break that off, so if you open up, you get all set out, putting a catheter in is like it's Boy Scout. Be prepared. You have everything you need up front, so that because once you touch the penis with your non-dominant hand, it's contaminated because you're only prepping the meatus, right? So you want to have everything set up so that you can just grab what you need. So as you're setting up, get your gloves on, whatever, break the catheter right then and there so that it's all done on the sterile field. I mean, yeah, there's a germ theory and there's germs in the air. Try not to sneeze on it. Try not to wipe it through the poop. What else? And then put the catheter in and hook the bag up, and that'll actually make it easier to do the Coudes. I'm actually kind of glad that way because then you won't have the bag tethering you from your balloon port at 12 o'clock, because what will happen is it'll twist it, and it won't be going right. So it's actually easier that way, except that you have to break the catheter, and everybody feels that that's a big no-no. I rarely put a catheter in with a bag patch, rarely, and we don't see people dying of urosepsis all the time. So. But that's a good point. Thank you.
Do you have any tricks for the little old ladies who come in with their knees contracted together and pulled up and just?
Or betadine. I mean, there's really, you're not going to be able, that's somebody who really ought to see us, and ought to need a super viewing too, because those, and it's really sad, but those contractions are terrible. I mean, there was one guy that had tons of kidney stones in St. Louis, and I mean, he literally looked like a pretzel. I mean, he was just so bent over. It's awful. But anyway, no, you can only thing you can do is try to make it as clean as you can, and then find the anterior vaginal wall and get a catheter. And it's really, that's a terrible situation, and it's not easy to deal with, but that's all you can do.
Lisa said you can backdoor.
Did not.
You can do it that way. I mean, it's still there. Yeah, there's nothing wrong with that. You just prep it out. That's fine. And I like that term.